Hello and welcome everyone. Thank you for joining us today for this pre-recorded webinar. Today we will be discussing optimizing team-based care and how it can be used to treat individuals living with diabetes. In case you are not familiar with Quality Insights, we are a nonprofit organization focused on healthcare quality solutions for systems, providers, and patients. This webinar today is hosted by the State Contracts team within Quality Insights. This important work is funded by the Delaware Division of Public Health. I will be your presenter today. My name is Courtney Masterson. I'm a practice transformation specialist here with Quality Insights, and I work on the state contracts team both in Delaware and Pennsylvania. I have a master's degree in healthcare administration that I employ while working with primary care providers to improve diabetes and hypertension outcomes within the state of Delaware. For my background, I have worked as a registered dietitian specializing in diabetes and end-stage renal disease. So let's start with defining what team-based care is. According to the American College of Physicians, a team-based care model strives to meet patient needs and preferences by actively engaging patients as a full participant in their care, while encouraging and supporting all healthcare professionals to function to the full extent of their education, certification, and licensure. This means that under the leadership of a physician, team members coordinate responsibilities related to different parts of the patient's office visit. With the help of other team members, physicians are better able to connect with patients and remain focused on patient care. This model, if done correctly, helps improve team collaboration, workflow efficiency, and patient satisfaction. So why should we be focusing on this collaboration? When each of the members of the care team are active participants and invested in patient care, the chances of catching something that may otherwise have fallen through the cracks increases. As front desk staff and MAs complete the check-in process with patients, they are regularly having conversations during this time, at which point the patient may mention something in passing that the patient may otherwise have thought to be irrelevant. If an office has a solid care team, this can allow providers to have a more comprehensive view of the patient. Situations such as the one described can contribute to benefits discussed on this slide, including the improving of the working environment, improving patient outcomes, and reducing unnecessary care and hospitalizations. The ADA encourages a team-based care approach to the treatment of patients living with diabetes in their annual standards of care. When the full team is engaged in chronic disease management, many benefits can often be seen for the patients. Additionally, the Community Preventative Services Task Force did a meta-analysis, which is a comprehensive review of studies around the team-based care model in diabetes and found that when executed properly, this model provided a plethora of benefits to both practices and patients alike. On this slide, you can see some of the benefits that were found. So who makes up the care team? Team members will vary depending on the healthcare setting, practice size, and services available. Regardless of who else is involved in the care team of the practice, the central member of the team should always be the patient. Healthcare has changed enormously in the last 20 years, and that pace has only been quickened by the COVID-19 pandemic. The rapidity of change will continue to accelerate as both clinicians and patients integrate new technologies into the management of overall health. It is also important to highlight that the care team can include both internal staff members, such as nurses and medical assistants, along with staff members that may operate outside of the clinic itself, such as pharmacists and dietitians. So why should practices implement team-based care? Unfortunately, while Delaware experienced a brief stabilization in diabetes rates in 2020 and 2021, the number of adult Delawareans living with diabetes has been steadily increasing in the last 20 years, with major increases happening in 2022, leading to more people who require additional care related to chronic conditions. Keeping this in mind, the research presented on this slide can be very concerning. A recent study found that the median amount of time that most providers spend with their patients was a little under 19 minutes. When the provider is the one taking on the onus of the work, including what is listed on this slide, such as reviewing labs and home values, reviewing medication, and providing education, it leaves little time for meaningful conversation around education or to identify and discuss barriers to care, which unfortunately presents us with a pretty bleak outlook looking forward to our healthcare in the coming years. And this problem is more likely to become worse as time goes on. The latest projections show that by 2036, the US will be short approximately 86,000 physicians. But in the meantime, we are only projected to have more and more people living with diabetes, with a staggering 60.6 million people estimated to be diagnosed with diabetes by the year 2060. However, for practices who practice team-based care, they tend to have better outcomes. Studies have shown that practices who implement team-based care have enhanced efficiency, higher quality of care, better patient outcomes, and also decreased clinician workload and burnout. This can also be extended by bringing in other healthcare professionals to encourage diabetes education and self-management. Here in the state of Delaware, there are several programs available to combat the lack of provider time for people living with diabetes. Referrals should be made for these individuals to programs such as the Diabetes Self-Management, Education and Support, or DSMES, DSMT, or Diabetes Self-Management Training, which is DSMES, but for individuals who have Medicare coverage. These programs are evidence-based and backed by the CDC to help the ever-growing need to help patients properly treat their diabetes. Additionally, at the bottom, we have Diabetes Self-Management Program, or DSMP. DSMP, however, is a less formal 6-week program hosted by peer coaches meant to offer healthy coping mechanisms and support. Despite these programs being widely available and the coverage of them expanding in the last decade, they remain criminally underutilized. As you can see on this slide, the CDC estimates that within the first year of diagnosis, approximately only 6.8% of privately insured individuals, 5% of Medicare beneficiaries, and 8% of Medicaid beneficiaries receive diabetes education in that first year of diagnosis. As of 2017, which is the latest data available, 15 states have regulations that require Medicaid programs to cover DSMES. Another 18 states cover DSMES for some or all of the Medicare beneficiaries through sub-regulatory Medicaid materials. For individuals who are unable to attend DSMES due to coverage limitations, DSMP does remain a potential for education as this program is free to participants. So why should your practice consider implementing a more robust team-based care approach? Besides the reasons listed above of why practices should employ a team-based care model in patient care, there is also a financial case for it. While the healthcare industry has been working to shift away from fee-for-service payment models to value-based payment methods, fee-for-service still remains the largest reimbursement model in the country, with other payment methods including pay-for-performance, capitulation, and shared savings/risk. In a fee-for-service model, practices are reimbursed by the number of services rendered. This means that if each member of the team is an active participant in patient care, that there is a potential for more services to be billed for during an office visit. As an example, a registered nurse or an RN can bill for annual wellness visits, chronic care management, and transitional care management using specific Medicare codes. The visit adds capacity to the physician's schedule, is fully billable, and increases access for patients. Similarly, if other team members can contribute to clinician efficiency and sustainability, allowing an additional 1 to 2 billable visits per half day. This is very beneficial under a fee-for-service model. MAs can also do tasks such as administering SDOH screenings or giving vaccines, both of which Medicare does reimburse for. Coverage for these types of services will vary from insurance to insurance, so make sure to check contracts. Value-based care, however, and payments have been incorporated into practices in a multitude of ways. According to the Healthcare Payment Learning and Action Network, or LAN, about 60% of healthcare payments in 2020 included some form of quality or value component. That number is up from 53% in 2017 and from only 11% in 2012. Practices involved in ACOs or another form of value-based reimbursement can also benefit from team-based care models as it has been proven to improve outcomes for patients living with diabetes. On this slide, you can see just a few of the study findings on the financial benefits around DSMES participation. In the top statistic, you can see in a retrospective study that patients who participated in education had 39% lower annual healthcare costs compared to those who did not receive education. Also, they tend to experience lower acute care costs, which are offset by higher outpatient and pharmacy costs for those who use diabetes education, but ultimately saving due to fewer emergency department visits, hospital admissions, and readmissions. And finally, a study published by Smith et al. Found that for individuals who participated in diabetes education, healthcare cost savings related to improvement from participation were estimated to be between $5.3 and $5.6 million over 2 to 3 years. The same meta-analysis that was discussed earlier on in this presentation found that team-based care resulted in decreased A1Cs, better blood pressure control, and also that these patients had better lipid panels overall. All of this is very important for those individuals living with diabetes as they tend to go hand in hand with cardiovascular disease. It is important to acknowledge that in healthcare, ROI, or return on investment, can be looked at in a multitude of ways. In addition to the straightforward financial benefit of self-management programs, returns such as improving coping and quality of life need also to be examined. Participation in DSMES, as discussed already, has been shown to reduce A1C, and that also leads to reductions of onset or worsening diabetes-related complications and reduction of all-cause mortality. Conversely, it also improves quality of life and promotes healthy lifestyle behaviors. As stated in my introduction, I do have a background in dialysis as well as diabetes education, and the best way I can think to put it is that it's very hard to have a very good quality of life when you have to go to dialysis 3 times a week. The more people that we can provide education, the more people we can keep off dialysis. So now that we have walked through why practices should implement team-based care into their daily workflows, how it can improve patient care and outcomes, let's talk about implementation. On this slide, we have several tips for how to incorporate changes into your current policies and workflows. We want to start by not jumping first into making major changes, but implementing one or more small changes or testing these changes with a small group of patients. We want to include all staff members in decision-making, allowing them to discuss where changes could be most beneficial, as it will affect each staff member. As an extension, include staff members in workflow changes and the establishment of new workflows and the processes that will define each team member's roles. This can help boost communication and collaboration. On this slide, we have some typical staff members for most offices, along with tasks that they can assist providers with. While there is a lot of information on this slide, it is important to look at the final column to think about what benefits your office would most want to strive for when looking to make changes in your current practices. In addition to these internal team members, I do want to highlight that utilizing external care team members, such as dietitians or pharmacists, can also have a big impact on topics such as patient outcomes, hospitalization utilization, and clinician workload. This information can also be found on the handout that was provided alongside of this presentation. A position that was mentioned on the previous slide, but I very much want to highlight, are community health workers. Community health workers can be a very valuable addition to any provider office. They are able to help patients by addressing non-medical concerns. They can conduct social determinants of health assessments and also connect patients to resources. Additionally, they are able to act as peer coaches and to provide informal counseling and education. In Delaware, the Community Health Worker Association of Delaware is advocating for voluntary certification for community health workers. Studies have shown that community health worker programs do have a return on investment of $1.80 to $2.42 for every dollar spent on community health workers. On the left, you can see the core competencies of the Delaware CHW Association. Unfortunately, at this time, Delaware Medicaid and MCOs do not reimburse for CHW services. Some CHW work is funded through state and federal funding targeting priority populations, which is something that can be looked at as a way to fund a community health worker within your practice. Reimbursement support is growing and has continued to expand. As of 2021, 21 states have authorized Medicaid payments for certain CHW services. On this slide, we have just some of the examples of workflow modifications that practices can implement that can help optimize the use of their whole staff in patient care. This includes things such as standing orders for referrals to DSMES programs for patients who are living with diabetes. MAs or LPNs can check lab and testing completion prior to the visit date to ensure best care. Or we can employ MAs to scribe during visits into the EHR so clinicians can focus on patient-centered communication and active clinical decision-making with the patient. Finally, we will run quickly through some of the different stages of office visits and discuss more expanded versions of modifications that can be implemented. Some pre-visit modifications that can be done to a workflow is that prior to the clinician entering the room, medical assistants or nurses can address things such as pending orders. They can perform refill management, assist in agenda setting for the visit, and begin preliminary documentation to allow the provider to know what needs to be addressed in this visit. During and post-visit modifications can include things such as having the staff dedicated to scribing appointments. During the after visits, the staff can perform documentation as well as record new orders per the clinician's orders. And additionally, they can pen the orders for the clinician's completion, as well as review the after-visit summary with the patient and perform basic health coaching. Another place where staff members can be employed is to have staff such as the front desk or MAs examine incoming test results. If labs are normal, they can then be tabled for the visit, or the MA can call to follow up with the patient and inform them. And any abnormal results can then be passed on to the clinician for addressing. We thank you so much for joining us today for this recorded presentation. If you have any additional questions regarding team-based care, please feel free to reach out to myself, Courtney Masterson, or you can discuss it with your practice transformation specialist. On this slide, we also have a link to our state services website and a QR code to allow you to access it remotely. Thank you so much for joining us and have a good day.